Hello friends, I am Dr S S Gambhir, Senior Consultant Plastic Surgeon, Sir Ganga Ram Hospital. Welcome to my YouTube channel. Today we will discuss a case who lost lot of weight by diet and exercise, and he has loose hanging skin both in upper and lower torso. But this time he wants to correct the upper torso, so we'll discuss about the upper body lift. He wants a masculine chest, so we'll discuss how to assess it, how to do the marking, while doing the procedure, what key points to be taken care of to give the optimum results. This is the patient. He has lost about 40 kgs of weight with diet and exercise. You can see the skin is loose hanging. You can see from the side, the upper torso, both the sides. On the other sides also loose. From the front, it seems the whole chest has fallen over the abdomen. The upper marking of the excision is done at the level just below the origin of the pec major muscle, going laterally towards the axilla or the lateral edge of the pec major muscle. Lateral laxity is moved in a way that the skin is brought towards the axilla in a J-shaped fashion, followed by taking the incision to the back and removing the extra skin and removing the dog ears. Now you see the marking in front, the upper marking. Once he raised the hand, you can see the lower part of the marking also. You can see from now. He will turn towards the one side. You can see the lateral part of the marking, how it is going towards the axilla and then gradually turning towards the back in ellipse fashion, not crossing the midline. Is placed in a supine position with both the arms abducted, and then we reconfirm the markings by bringing the skin together, especially within supine position. We use the stapler as well as the cover clip to bring together the skin as much as we can, and then reconfirm our marking in the lying posture. We redraw the marking with the amount of skin that is possibly to excise in the lying position. Then the vertical lines are placed so that we don't miss them during the suturing. The staples are removed and the skin is excised. The upper incision is given first. We cut the skin, goes up to the deep fascia. You can see the lower edge of the pec major muscles after we have cut deep, which will be shown, and we try to bring the skin down to the lower edge of the origin of the pec major muscle. You can see the muscle origin there, and the lower flap is elevated in the lower margin. From the lower part of the pec major muscle, the fascia to the skin and sutures are taken to form the inframedullary fold. This is taken 3 to 4 sutures on the lower part and 2 sutures on the lateral part of the pec major muscles to form the masculine chest. This is very important suture. It's a very strong suture. The extra skin of the upper part is excised, and this upper part is then fixed laterally to the pec major muscles fascia on the lateral edge. The nipple area complex is then removed as a composite graft. After the marking, the whole of the composite graft is then excised, and after that it is once excised it is thinned out to form a full thickness graft. This is then stored in a cold saline gauze and kept separately. The lower flap is excised from the lateral part first, the the marking which is then brought to the upper marking first and then sutured, and then we excise the whole of the lower flap along the marked line, and the tissue is removed. The upper and lower flap is sutured in layers using Vicryl 20, 30 and Monocryl 40. The flap is excised as much laterally as possible in a supine position, and once everything is closed on this side, we then go to the other side, and then completely the other side we then turn the patient on the lateral side on the both right lateral and left lateral to complete the excision part. Once one side is complete, then we do the similar process on the other side. First tying with stapler and double clip, remarking it, excising the upper margin first, and then we go towards the lower margin after fixing the upper margin with the lower part of the pec major fascia. Once it is done, then the lower flap is excised.
This patient had a sebaceous cyst on the central eastern area, which is excised. The last sebaceous cyst which was excised, and both the edges, middle edges, have been got in continuity. Once suturing is finished on the other side, the patient is turned laterally, the right lateral and then the left lateral. Both sides are complete. Once the suturing is done on the back area, the patient is placed in a supine position, and then we do the marking for the nippler complex. The nippler complex is marked 1 cm above the suture line and on the lateral edge of the pec major muscle. We deep flex the skin. After deflection, hamstring is maintained, and then the graft, which was initially taken out and kept as a full thickness graft, is then placed. After placing the graft and suturing it, we put a dye over dressing. You can see the amount of skin excised in the front and the back end, and then you can see the suture line and the thyroid dressing on one side and the nipple graft on the other side is there. This is 10 days after the procedure. The graft has stuck well, taken off well. Suture line is healthy and is nearly symmetrical in shape both in the front area as well as in the back area, and you can see the pec major masculine chest in this patient. On the lateral side, then the front side.